How's it going, guys? Medium difficulty question for renal step 1 internal medicine 2 CK. 46-year-old man. He's being managed in hospital for a severe autoimmune flare. 1 year ago, he was managed for necrotizing sinusitis. BUN 200 should be under 20. Creatinine 7.1 should be 0.7 to 1.2. Once you've hit a creatinine of 2, you've lost 90% of your renal function. So this guy has 0 renal function. He'd be on immediate hemodialysis. Urinalysis shows 2 plus blood, 1 plus protein. Physical exam shows a left foot drop and frost on the legs, torso, and face, which the font most likely be seen as patient. So this image here of the histo, very buzzy, for showing us a fibrin crescent. Okay, so crescentic glomerulonephritis, aka rapidly progressive glomerulonephritis. This image you got to know. And then this image of the knee here, very recondite and obscure. This is uremic frost. Holy shit. So this is urea crystals that can deposit on the skin, cause pruritus, generally with a BUN over 200. So, and I talk about it in my renal PDF. Okay, so let's just hop to the answers. What are we going to see? Choice A, anti-CCP antibodies, wrong fucking answer. They're the most specific antibodies for rheumatoid arthritis, although rheumatoid factor, most sensitive, which is an IgM antibody against the FC region of IgG. RA, 1 out of 10 questions for renal amyloidosis can be autoimmune disease like RA. I've talked about how 9 out of 10 times renal amyloidosis will be multiple myeloma. RA, autoimmune disease in general, RA, SLE, can cause membranous glomerulonephropathy as well, which would be a nephrotic syndrome. You wouldn't have blood in the urine. Wrong fucking answer. Choice B, anti-double-stranded DNA antibodies, wrong fucking answer, of course, refers to lupus. So I'm going to tell you exactly what you need to know. It's going to be very clean and simple, okay? If you get an SLE vignette and you have lupus nephritis, if there's blood in the urine, that's going to be DPGN, diffuse proliferative glomerulonephritis, is the answer. Okay? Nephritic syndrome. If you get SLE and there's no blood in the urine, that's going to be membranous glomerulonephropathy, as I just mentioned, that you can get with RA autoimmune disease, right? So I would say probably 7 out of 8 times just going to be DPGN. So you can just memorize that. You get a big fucking rambling 15-line paragraph, some patient with SLE, said there's red urine. Okay, and the answer is just DPGN. In this case, wrong fucking answer. Choice C. Actually, I'm just going to draw a parallel here just because of the comparison. So, as I mentioned for choice A, anti-CCP is most specific for RA, but we tend to see rheumatoid factor more often, more sensitive. Similarly for lupus, anti-Smith antibodies, holy shit, are actually more specific for lupus than anti-double-stranded DNA antibodies. Anti-double-stranded DNA antibodies are more sensitive. Wrong fucking answer, as I already said. Choice C, anti-GBM antibodies, wrong fucking answer, refers to Goodpasture syndrome, male 20s to 40s, hemoptysis, hematuria, okay? And this can cause rapidly progressive glomerulonephritis. It can, okay? But the rest of the vignette doesn't match, which I'll talk about in a moment. And you need to know the anti-GBM antibodies are also known as collagen 4 antibodies. Wrong fucking answer. Choice D, Cienka, correct answer. Diagnosis, granulomatosis with polyangiitis, the new cumbersome name for Wegener. Okay, now Wegener is going to be a triad of hematuria, hemoptysis, which of course I didn't mention here because I'm being a flagrant asshole, but just hear me out. Hematuria, hemoptysis, and headitis is my colloquialism for any issue with the head. Sinusitis, otitis, mastoiditis, nasal septal perforation, okay? And you say, what's going on with the foot drop? That's mononeuritis multiplex, OMG, all right? So when we talk about the vasculitides, microscopic polyangiitis, Churg-Strauss, okay, aka eosinophilic granulomatosis polyangiitis, or Wegener, you can get mononeuritis multiplex, which is going to be one large nerve affected, such as the radial nerve, resulting in wrist drop, common peroneal nerve, resulting in foot drop. So one large nerve affected in multiple locations. I'm just telling you this because you might get Churg-Strauss, Wegener, microscopic polyangiitis on the NBME/USMLE, and you're like, what the fuck? Why is there a foot drop? Okay, so you can get neuropathy sometimes with it, and you can eliminate to get here because P-ANCA would be microscopic polyangiitis, doesn't tend to cause headitis. Okay, exceedingly rare that you'd get headitis with microscopic polyangiitis, which can be P-ANCA. And then you say, well, what else is P-ANCA? Churg-Strauss. And you're not going to, you often, you will get eosinophilia and asthma-like presentation, but it's more rare to get renal involvement. Okay, so it's the combination of the headitis here plus the hematuria with the rapidly progressive glomerulonephritis that tells us this is granulomatosis with polyangiitis. And I just want to let you know also, the USMLE can be real fucking audacious with how they write the answer choices. They can give you a vignette Wegener, and then the answer is just angiitis, or just polyangiitis, or vasculitis. Okay? Choice E, wrong fucking answer. You know the deal. I'm going to make more content if you like my stuff, subscribe my channel. And I appreciate your time. That's it.